So today we're going to review the case that you all turned in, the IMRT or VMAT treatment planning case that involves a simultaneous in-field boost on that. So to recap, the case involved three PTVs, a PTV 4500, a PTV 5000, a PTV 5500. So all of them were receiving 25 fractions. Again, this is a simultaneous integrated boost on the thing. So there were two suggested methods. Two suggested beam arrangements. So a VMAT arrangement involving two fields, a counterclockwise motion and a clockwise motion on that, or an IMRT arrangement involving five fields. So there were, as it says on the bottom, feel free to use any beam arrangement that you wanted to do. I do want to make a note of the IMRT. It was using 15 X's, and that's not something we typically would do for IMRT at Emory. And the concern with using an energy greater than 10 MV, of course, is the neutron dose that the patient would receive. So we would generally not do that. That being said, I did construct an IMRT field using 15 X's, and it worked fine, but we would not use that on a patient because of the neutron dose that comes along with that. So there were 54 plans that were submitted. There were 14 IMRT and 40 VMAT. So there's a fair breakdown. For the IMRT, there were 8 that did it with a 5-field arrangement. Only 1 did it with the 15 MV. But again, that's fine as long as you tell us what you're doing. So you can see there was a 5-field, a 6-field, a 7-field, and some people went all out with a 12-field and a 15-field IMRT plan as well. So the VMAT, there were some that settled in with a 1-arc plan. And then there were others that used 2, 3, and 4 arcs for that. I think that the dosimetrist I talked with here would probably have done a 4-arc. And if IMRT was the way to go, it probably would have been a 7-field. And one of our other physicists, Sean and I talked to yesterday, said they probably might even have gone up to 9-field with the size of these PTVs. So it wasn't just the PTVs at those 3 constraints that we had above. There were various evaluation constraints that we had as well. So the volume receiving 95% of the dose needed to be above 98% on that. At Emory, we would say that volume would be required to be 100%. So we would limit ours to the volume receiving 95% of the dose would be 100. But in this case, it's a little bit more relaxed and it is going to 98. And you see the other constraints then for the 5000 and the 5500. So you reviewed those all. These pop up in your scorecard. So it's not just that you met the values for the PTVs, but we're going to be scored on how well you did against these criteria here, as well as these OAR constraints as well. So you'll notice that there's some that have Dmax constraints, and then some that have additional volumetric constraints as well that we're trying to limit the dose to. So looking overall, and this is a busy slide, but it's all of your scorecards composed into one shot. So we'll look more at this in depth, but you can see that there's some trends that you can kind of see off of this. If you look at those that passed well, of course they passed with very little red, but you can see that those that didn't pass as well, the biggest thing that's going to get them is, or get you all, is how you treated the PTVs, how those PTVs met their constraints that were done. So, and you're going to see down here that these are the OARs, mostly Dmax or maximum doses being violated and so forth. I think that the VMAT or IMRT plan that I had was fairly high up, but it still had something that didn't quite meet up there. But you can see that this column down here kind of flows through all the way. Is really that you start seeing a dive in the scores when you start not meeting these PTV constraints on here. Looking at, we separated IMRT and VMAT, and really the same trend held through. You know, those that did IMRT plans, the same kind of distribution held for IMRT versus VMAT. There were some very good plans that came through with IMRT as well as VMAT. So going through you were handed out this Schulman kind of a recipe, right, on how to do a VMAT or an IMRT plan. It's a fantastic document. And just to recap some of the things that were in it, well, looking through all the things that were required in it and just reviewing them, what we were supposed to do. So the ZPTVs, they're designed to help any critical max dose OARs during the planning. So the key is, you know, some of your OARs are going to overlap with your PTVs. The problem that you have is if your OAR has a maximum dose that's less than the value of the PTV, okay? And if that's a high priority OAR and you need to meet that constraint, what you're going to do is you're going to have to crop back your PTV. You're going to have to talk to your physician and say, listen, if I'm to spare that OAR, then I need to back off the PTV. So looking at what we had ideal maximum doses of various ranges, and they overlapped. Some of these overlapped with these first 5 overlapped with PTVs. But in all situations, the maximum dose for that OAR was greater than the PTV. So we did not need to use any Z PTVs. Now, that being said, we're gonna go back into our other structures because we did have problems with some of these maximum doses failing in those PTVs. So we're gonna have to deal with that with another structure. But that's not, we're not altering our PTV because of these maximum OAR constraints in this case. So we didn't have any of these Z PTVs that we constructed here. The Z OARs in PTVs would help protect mean doses. Our cases, we didn't have any mean doses. In this case, you would kind of take out the rest of the OAR that's not in the PTV and force that dose to be as low as possible, so that when you average the entire OAR, your mean dose would be very low and you can meet the constraint. So we could do that with a series of looking at the entire OAR outside of the PTV, or we could scale that into various segments, is what they talked about in the Schulman thing. And then you could constrain your OAR dose in that way. So we didn't use any of these Z OAR in PTVs in our case. A Z PTV underscore opti dose is really necessary in this case, right? Why? Because we had PTVs that overlapped each other. So we had a PTV 4500 that overlapped with PTV 5000 and PTV 5500. If you don't pull out those PTVs, your optimizer is going to be fighting with itself. Okay, it's going to be fighting with itself. It's going to be trying to lower the PTV 4500, and it's going to be trying to hold the dose of the PTV 5000, PTV 5500. So you're going to see a problem not only at the PTV areas, but you can have problems all the way around your PTV 4500. You're getting hot spots all over the place because it's fighting against itself and it can't deal with that. So it's very important to construct in this case, a PTV, a Z PTV underscore opti underscore 4500 that takes out these PTVs here. And then you'll use this structure in your optimizer. Okay. So in your Schulman recipe book, you'll see what the margins are. And here I plugged in those margins for this case. The margins are dependent upon the difference in doses between your 2 PTVs and how quickly you want them to fall off between those PTVs. So the margin around the PTV 5000 is going to be through this formula, and you're going to find it's going to be about 2 millimeters. And the margin around this should be 5500. On the PTV 5500 is going to be 3.6. So again, correction there. So what does that look like? Here we see our PTV 4500 and our PTV, in this case, 5500 in all 3 planes. And when you construct this new PTV opti 4500, you're going to see that you've pulled back away with about 3.6 millimeter margin away from that PTV 4500. Okay. So you'll use this for your optimizer. You'll use that for your PTV optimizer. And here it is as well with your 5000. You can see the margin's a little less for your 5000 because you're only going from 5000 down to 4500. So you can have less margin on there. Now you can be assured that the dose is going to be fine in here because this is going from 5000 to 4500. So you should have no problems with it, but it allows your optimizer to perform better. Okay, an OptiRind. An OptiRind helps get good coverage in your PTVs. Okay, in this case, we're going to construct rinds for our Opti 4500 because that's the only one we had to create an Opti structure for, and our PTV 5000 and PTV 5500. The rind itself is going to pull back 5 millimeters from the outer edge and just take a segment around that PTV, and it's designed to force the optimizer to push dose out to the edge. We're going to see a lot of these cases did not have these OptiRinds, and you didn't get very good 4500 coverage. As a matter of fact, if you looked at the scorecard that I had before with all the 54 cases, if you look down at the bottom, this was the cause of that problem there. So here's your, for example, on how these OptiRhines, here's a 4500, the PTV 4500, and here's the OptiRhine that you would use in order to, for that 4500. So this would be another structure on top of your Opti 4500. This is an OptiRhine 4500, and you would use this to force the dose out to that outer edge. And likewise, you would do the same things for your 5000 and your 5500. Opti corners, I didn't use any of these, but they're designed to force the dose out to the edge. So remember, when you're dealing with this optimization, if you want to force things, if you want to force the optimizer to look at a particular point in your PTV, what you can do is you can segment that out, that point out, and you can give it a priority, right? You can give it a constraint and a priority and force the optimizer to center in on that point. And that's exactly what the Opti corner is going to do. Likewise, if you have hot spots, you can actually take those isodose lines that are hot, create a contour out of that, and you can actually force those to be forced down. Okay, so you can trick or you can finesse your optimizer in various ways. Opti corners is one of them, and creating isodose, or high isodoses, and create contours out of those, and optimizing those down is another thing you do. Rings are used to drive the optimization process, and is designed to quickly reduce the dose outside of your PTVs. Okay, it's similar to the NTO, except it really is forcing that dose to go lower over a quicker section, over a quicker distance. Okay, so we were called to create 2 rings, and when you create these rings, you always create 2 rings. Do it in 2 steps. If it gets too thick, it doesn't really quite understand how to drive it from one down to the other. So you create 2 different rings. An Opti ring 1, first ring is done by taking 1 millimeter margin away from your PTV 4500. In this case, it's away from your PTV. Please mute if you could. So we're picking up, thank you. So the first ring is going to be 1 centimeter thick, but it's going to start 1 millimeter away from the PTV that your 4500. In this case, it was, yeah, PTV 4500. From that, you're going to subtract out the distance of PTV 5000 plus 3 millimeters. And you're also going to subtract out PTV 5500 plus 5 millimeters. So you're going to push those doses out from there. Opti ring 2 is going to be contiguous with the outside of Opti ring 1, but it's going to be an additional 1 centimeter on there. So what does this look like? It looks like this. So here you can see I believe this is PTV Opti 5. Sorry, this is my PTV Opti 4500. From that, I constructed the first ring, and the second ring is 1 centimeter thicker beyond that first ring. And you can see what that looks like in the 3 planes on that. If you look in the upper corner, in this corner here, you can see that there's an additional margin. This is the 5000 PTV. So there's a little bit more margin that's trimmed around this. And if I had shown you the PTV 5500, you'd see that have a little bit more margin even still. And then the normal tissue objective is it's a contour that includes everything but the PTVs. Okay, so the whole design of the NTO, it's automatically created with the clips. With Monaco, it's going to be something that you need to do. But if you're contouring everything outside of your PTVs, and what you're trying to do with that is you're trying to hold your dose down as low as possible. Other planning structures, and I bring this one up. It has it in your recipe book, and I bring it up here because we did use another planning structure. Then something was very useful was creating an overlap structure of your OAR and your PTV. So when, say, for instance, your bladder, and I'm going to, first of all, I'll state that the purpose of this is used to decrease the dose in the OAR below the OAR maximum. So lots of us have problems keeping the dose in the bladder below 47.25. Okay, it's sitting inside the PTV 4500, but it got more dose than 4500 when it overlapped. Okay, so a useful structure is to create a structure such as this, which is the overlap structure, and then to optimize to have 0% of the volume in that structure receiving 0% of the volume will be receiving greater than 47.25 dose. Okay, that was our constraint, our maximum dose on our bladder. So if we want to do that, we can force that structure to have less dose than that. So it's going to keep our bladder maximum dose down, and it still keep our PTV at 4,500. So those are the those are the things that we had to deal with. Those are the structures that we needed to create. Before I jump into plans, I need to give thanks to Kirk Luca, who's our dosimetrist, one of my dosimetrists that really helped out with these plans. And then Justin Roper, who's another physicist that Sean and I talked to yesterday to work through some of the issues as well. So two thanks to these people. And let's take a look at some plans now. And this might get a little rough, so let's see what we can do. So here are your plans. And let me just start with this. So we were able to construct a collection of your 54 plans. And I do want to make some observations here. So looking at a composite of all your DVHs. So this is your entire DVHs. I should note that there's, starting with the 4,500, and Sean, you can jump on in if you got something to add here. There was quite a wide range of values here. Okay, so this is looking at 54 different DVHs all comprised into one DVH curve, and you can see there's quite a spread going on with the PTVs. So that's one thing for the PTVs, and these should be probably, you shouldn't see any cool areas. It should be a lot tighter than that, but you really should see a lot of more tightness when you look at the composites of all your OARs. I mean, here is a huge spread in bladder doses. So when doing plans, not only do we look at the constraints for the PTVs and the OARs, but generally you really want to hold your OAR doses down. So you really want to keep things as low as you possibly can achieve. We would prefer to have, for like spinal cord, we would prefer to have some wiggle room if we have to bring a patient back in to have a retreat, right? You can see in this case, I mean, for a spinal cord and the spinal, we're kind of pushing up on that 4,500 centigrade dose. So you generally want to hold a spinal cord down, and you should be able to hold. We try to limit our doses at Emory using constraints to constrain our dose down to about 30 gray for if it involves a cord on that. Okay, so let's jump on into a actual plan, and I'm going to pull up the one that I did first, and I shouldn't say I did. I can say the one that my dosimetrist did. So I want to point out first the structures that were created. Right, let me turn the dose off. So structures that were created, quite a few of them. So we started with a PTV 4,500 and 5,000 and 5,500. From there, we created an OPTI structure, right? So the OPTI removed the dose out to the outside. From there, we were able to construct the rind as well, which forces dose out. And we did that rind for all the PTVs that we have out there. We then constructed rings as well, and that forces the dose down where we need it to be. Then we were all given the bladder, various OAR constraints as well. One other structure several other structures, since we had issues with the bladder, constraining that. Turn the bladder on. I put a constraint in for an overlap for the bladder, an overlap for the bowel, an overlap for the duodenum. Okay, so these are all designed as tools to limit the doses that overlap with the PTVs to keep those maximum doses down. Okay, so from that, then the optimization process proceeded as planned, and we were able to get dose distribution that looks something like this. So move this up so you can see, and turn my doses down a bit here. Let me change this to 45. This guy is at 40. We had another constraint of 47.25. So let's just stop there. Turn this off, turn these back on. And you can see that we were able, I'm sorry, I've got a lot of structures going on here. So you're probably saying that that's not a great dose on the PTV 45, but actually matched remarkably well. So I should shine back on the 48. All right, but the scorecard would show that gave a reasonable result on the results. So looking at that, then it comes up with pretty good value. The DVHs, the 95% of the DVH 4,500 received 44.5, and then you can see that the constraints that are down below here. So with that being said, let's pull up some other patients on there, and Sean, jump on in if you've got things to add to this. We're going to start with this one here. All right. On this plan, and please don't take offense if this is your plan, because we're pointing out things that we can work on, and that's the purpose of this, is to have some constructive criticism on that. So I don't, if I pull your plan up, please don't cringe. They're teaching moments. Note the structures on this. We don't have an Opti 4500, okay, and we don't have a rind around any of the PTVs either. Okay, so what we see on that is we see several things. We see, from the lack of rind, that we don't see a whole lot of dose being forced out to the edges of that PTV. And second of all, we see these hot spots. This is a 50 gray hotspot in a 4500 PTV. We see these hot spots that come throughout. Looking at this is the 45 gray area. Again, this is a PTV 4500. We don't see this PTV filling that in. So what the problem is we've got a PTV 5000 and a PTV 50 in there, and it's going to be battling. It's going to be battling with this PTV here, which wants to be at 5500, and this PTV here, which wants to be at 4500. So it's trying to deal with hotspots that are existing over here, and it doesn't have the energy to be dealing with hotspots that exist over here. Okay. So it's very important that we build that Opti structure to remove these PTVs out. And it's also very important that we design a rind around there to keep the dose moving out of those into that PTV. Sean, do you have anything else to add to that? I think I covered everything.
That's what I was going to say. Yeah. So the rind would be, yeah, like you said, to push the dose and towards the bladder. You saw it a little cool, and it was probably trying to reduce the dose to the bladder as well. But that rind would help to bring the 4500 out while still reducing your bladder dose. And you can see the dose creeping out from your PTV into the bowel, and that's that's part of what Eric was saying with the rinds and such, to try to keep your prescribed dose within your PTVs and not so much start to bleed out into normal tissue.
We're going to move on to the next case. The next case is this one here. This, if you looked at their scorecard, and it struggled with the dose to the duodenum and the dose to the bladder. Okay, and you see that here, let's pick on the bladder here for a second. This is the issue with this one, is we don't have any structures that are designed to optimize this out. Okay, we're dealing also with the fact that we don't have an Opti 4500, which removes those other two PTVs. We're going to have spatterings of high doses out throughout the PTV, but we also don't have any way to deal with the bladder itself. Okay, so one way to deal with that would be to construct that overlap structure and then optimize to limit the dose to less than 47.25. So put a high priority on that, make the dose that you want zero volume in this new volume to receive. 0% of that volume should be receiving greater than 47.25 at a high priority. Right. And that'll drive that dose, but it won't.
Sorry, go ahead, Eric.
Yeah, but it won't affect your 4500 PTV. Go ahead, Sean.
Right. No, I was just going to say, just note that if you use a rind and you use this overlaps, you don't want them battling each other as well. So just make sure your constraints are set appropriately.
And then Sean, you want to bring up the rectal dose? You talked about this yesterday.
Yeah, it looks like, aside from the fact that there's not like that bladder overlap structure, it looks like because that wasn't there, in order to compensate, maybe we can't see what the objectives were in the optimization, but it looks to us at a quick glance that maybe the optimization was focusing more on the rectum than the bladder. So it pushed the hot spot away from the rectum and into the bladder. So that avoidance structure, like what Eric was talking about, might have helped that, and also to maybe equal out your objectives on your OARs, so they're not trying to fight each other so much, especially if they're kind of close proximity to each other.
Okay, let's jump to the next one. We have got this one here, and Sean and I'll confess we use Eclipse, so we don't fully aware of what Monaco is doing, but it struck us both as a little unusual to see our dose down into our couch area. And I'm not sure whether this is using Monte Carlo. I mean, it may be or may not be. I don't know, but that was a little unusual for us. So we're not sure what's going on with that.
Right. Yeah, it almost looked like there's questions, and like Eric said, we're not picking on anybody. We're just trying to make sure that, this is educational. We know there's dose in the couch typically. There's a transmission factor associated with it, but typically you don't see the dose being accounted for in it. And the doses in this are significant, so it almost looks like the density of the couch may be off. And also the fact that you even see it, it almost, like we said, we're not familiar with Monaco, but it almost looks like the couch is part of the accessory to the beam. But again, we're not familiar with it, but it struck us as unusual.
And we did go back, and there are some tools in here. We did check the Hounsfield units on your couch, and it looks normal. So I just don't know why the dose showed up in there. And remember, dose is the energy over the mass, and this is a low mass area. So you're dividing by a very small number. You will see dose. If you look at plans, you'll see dose in areas, but normally we don't display that. And but it's showing up, and it is what it is. But that's that.
Sorry, Eric, there was a comment in there that said it is normal in Monaco. There were several Monaco plans submitted and we didn't see it. So it still was a little odd. And it's not to say anything's necessarily wrong, but it was just an observation that was odd or unusual.
The one thing I want to point out is this plan does have a ring, which is a nice thing. It's got a ring, but we still seem to get a lot of dose coming out here. This is a VMAT plan. And you would usually see these with IMRT, but we're seeing it's a lot of dose coming outside in here. So it might be that we really should force this into 2 rings and kind of force that dose down faster. It may be struggling with the ring so thick to limit your dose outside the field. But that seems that this needs to be dealt with, because this is 33 gray out the outside, which is kind of a little excessive on that. So, Sean, anything else?
No, I agree. It does look like an IMRT plan somewhat, and sometimes we'll see if you're not using the NTO or the rings to keep your dose closer to the PTVs, you may see those streaks out if it's trying to push dose to a structure that, if in certain parts of the arc it's trying to avoid bladder, rectum, or normal structures, it may try to compensate by trying to push it through a section of the arc that's not seeing those. And so you may get those spikes that go out like that. And so your NTO or your rings will prevent that from happening.
The topic of the Rhine, and I think since Sean read one of the comments, somebody, I think Kamal asked a really good question, that can you give us an example of a perfect Rhine? And then Bob also asked if it's advisable to plan a chest case with VMAT, and if yes, how do you account for breathing, assuming you don't have any breath hold equipment in your institution?
You want to let's start with the rind, Eric. I guess you can show them your case.
Yeah, so I mean that sure, we could show that.
Yeah, the rind is helpful because if you have these things trying to push dose in and then push dose out, the rind helps to focus that dose on the edges, because you got your NTOs and your rings that are trying to push it in. And then you have your objectives that might be trying to, maybe push it out a little bit. So the rind will help you to focus on that area where there's a little bit of a battle going on.
Yeah. So, I mean, again, we're looking only at 95% of that, 95% of the volume needing to be at 98 of the PTV. So you're looking to force it out as much.
A question, Kai?
Yeah, you can ask your question directly.
Okay, fine.
Yes, go ahead.
This line, are we creating it inside the PTV or outside? The ring is outside, right?
No, the ring is inside.
Inside.
Is right inside.
Inside the PTV.
5
Right.
millimeters inside the PTV. So what
Right.
you're doing?
What
Yeah.
about the line?
The rind is on the inside, because the rind is like the edge of think of an orange or something, the rind, and it's the outside part. So you're trying to push dose, you're using that as a structure to try to drive the dose to the edge of it. Otherwise, it can be hotter in the middle and it'll start to taper out too quick your coverage on the edges of your PTV might be too cold because of normal tissue around it or OARs. And so that rind helps to get you within or close to your objectives, like the 95% to 98% of your volume. It might help to try to push that out to it. So you need it inside.
So here's the PTV itself. Here's PTV 4500, right? If I turn the rind on and turn the PTV 4500 off, so now you're looking at just the rind. It's this volume in between these two lines. And you can see that on the sagittal and coronal planes as well. It's this area in between the two lines that you're doing. PTV 4500 includes everything. The opti ring includes just this section in here. So you're optimizing to force dose into here, and the opti 4500 is doing the dose to everything. Okay, so the ring itself is just centering on the outside 5 millimeters of that contour.
Now, my second question is all about the organ set risk. When you're creating that is the ring allow the organ set risk, is it advisable to create a secondary organ, let's say bladder? There is that part which hasn't closed to the PTV region. Is it advisable to crop to get a secondary organ by cropping the area that is not infiltrated by the PTV?
You would use that for, so like the bladder that's not overlapping with the PTV. If you were to use, you would use that to help your mean dose.
Yes, because that's, I remember in one of my earlier trainings, it used to give us, you crop the area, and that's what I did in my plan.
Mm-hmm.
Okay.
Yeah.
Yeah, that would be very useful. I mean, we use means quite a bit here, so it is useful to follow that recipe, if you will, to force that area to be low, because you're kind of, if you're going to try to get your PTV to its dose and the bladders included, I mean, you got a high dose, and if your mean dose is lower than that, you really need to find your savings somewhere else, and that's going to be outside of PTV.
Right, and to add to that, the doses were pretty similar between the bladder and the PTV with respect to 45 and 47.25. If there was like a larger discrepancy in dose, like the OAR had to go to something significantly lower, they wouldn't necessarily like be right on top of each other. There would be a gap between the bladder and the PTV to try to give that gradient between the two, because if you try to do 6,000 here and 4,000 here with no gap, it's difficult for the optimizer to try to achieve that. So just know that if your PTV and your OAR do have significantly different dose requirements, you want to put a little space between the two.
Good. All right, let me jump to the next case.
Do you want to just mention the chest wall real quick? I guess it's not really.
So the chest wall question was, how would you do that without breath hold ability?
Yes.
So I'll just start real quick. Yeah, I mean, we do VMAT plans on our chest wall. Well, if you say chest wall, you're talking about like intact breast or breast treatments, basically. Is that the question? Or is it like chest wall lung or because we don't typically do VMATs for chest walls like a breast treatment. We do tangential fields. We do, compensator-based type treatments, electronic compensator. But if you're talking about like a lung or something like that, and you don't have gating, ITVs, if you can do, the full motion of your PTV or your GTV and then draw that in, then you get the range of motion that you're going to treat. I don't know, you want to add to that, Eric? I mean, VMAT chest walls aren't like a common occurrence unless you have nodes or something. But to account for the breathing, and that may be one of the reasons why we typically don't, is just because you do have the motion if it's a free breathe with the chest wall anatomy coming in and out of the beam. You never know where you are each time.
I don't know that was a good answer. I'm not sure I could even touch on it.
Yeah, I mean, unless you were able to somehow do for a true chest wall VMAT, unless there was some way to monitor a true breath hold, it would be difficult to do. So not to say we would it's our recommendations. You shouldn't do it, but we probably wouldn't do it unless we had the capability to do like a breath hold. Just our suggestion.
Kindly, maybe probably I can ask this on such a scenario whereby maybe for a case of halcyon, whereby you only have IMAT, mat, and then you don't have it doesn't have wedges, then what is the that is the practical way of doing a best that is a breast run?
On a halcyon, you said?
Yes, halcyon.
That's a good question. We are getting a halcyon. We don't have one yet. We'll actually have it in December. So we can't say from experience on that. I'm sure there are planners out there who routinely do breasts on halcyons. I know there are. So that might be a question for somebody who's experienced with that. It's not something that we routinely do. So I'd be hesitant to give my recommendations on that just because I'm just not experienced with that.
Check back in a year.
Or we could, yeah. I mean, there's probably sources out there, even through Variant or such, that could help you with that question. But it's a good question, and it's a fully legitimate question. If your only machine is a halcyon and you're trying to treat breast and chest walls, then yeah, and you're concerned about motions, and that's 100% a legitimate concern.
Thank you.
I think as a follow-up on the IMRT VMAT debate so Victor is asking that is the recommendation of IMRT versus VMAT only for left breast or also for right breast and chest wall? And there's also, I'll let you answer that, or if we can combine all the questions and ask it at the end of the class, that's also great. But I figured since we're on the topic of chest wall, I wanted to drop that in.
We really don't do IMRT for left breast or right breast. We do field and field techniques for that. So we're using more of a 3D conformal, if you will, on that. And we use a breath hold technique for left breast, and we do not do a breath hold for the right breast. So that's the difference. Is
that's to spare the heart. Yeah.
So we don't do VMAT or IMRT for either situation. So
it's rare. Like I said, we will occasionally on some really complex and long, or with the nodes in the middle and then big volumes, we might do a VMAT. But our physicians don't routinely do it, and then you do start to see your lung dose kind of creep up a little bit. So it's not our practice. So I know a lot of places do IMRT and VMAT for these, and that's if it works, that's fine. But it's just not our physician norm.
There's a follow-up that why I would like to know why you do not do IMRT or VMAT for chest wall. There's a follow-up question from Nish. I think that's a pretty good question.
Yeah, and again, we're not saying it's wrong. It's just not the practice at Emory, and so it's just not in our toolbox to do these unless it's an unusual case. It'd be best to do any kind of these type of modulated treatments where you have certain parts of the anatomy blocked at times with the MLCs and such, to be able to reproduce that every time. So breath hold is best to do those with. If you don't have that capability, then you have to be a little bit more relaxed with modulation and such. That's my take on it. And absolutely not to say it's wrong, because I know halcyons do it and a lot of places do that type of treatment for breast and chest. It's just not the practice we use at Emory.
I think Jasper is also asking that the Shulman method has been talking about how to manage the max and min dose for OAR overlap with PTV. In the case of volume dose constraint, that is not more than 30% of the bladder should receive 45 gray. What will be the best way to manage this? I want to believe that was what you talked about in creating an optimization structure by subtracting the overlap, but I will let you answer that question.
Yeah, so if you've got a volume constraint that's a 45 gray and your PTV of 45 gray is overlapping that, I mean, that's hopefully you don't have 30% of your volume overlap with your PTV, because at that point, then you're going to talk to your physician and figure out, you're going to figure out what has to give, right? Your PTV coverage or your bladder coverage. You're sparing your bladder. But if you're looking for a happy compromise, you could create a little refined overlap structure where you could spare more of that receiving 45, more towards the, you could close down your overlap structure to include less of the PTV volume, if you would. Okay. And then constrain that so you would have less sacrifice of your PTV coverage. It'd be a compromise between PT coverage and your bladder 30%, if that answers that. Hope so.
Yeah, sometimes you have to just tell the physician, look, I can't meet both. You know, do you want to sacrifice PTV or you want to sacrifice OAR? And it's a physician discretion whether or not they want to, which one they want to do.
Okay. I think this is the last question here. I keep saying last and the questions keep coming in. Is there a difference on countering of PTV and OARs for VMAT and 3D plan? Let us speak specifically for breast, pelvic, and head and neck. Thank you. Also, Kazim, if you want to unmute and ask this question so that we can get it right, that would be great too. Because I want to make sure we're getting your question right.
Yeah, hello.
Hello.
Hey,
Yeah, the idea is there any difference in the contouring when the physician make the contouring for VMAT or for 3D specifically? For example, in head and neck case.
There shouldn't be. I mean, if you're contouring your PTVs or your OARs, they should be the same from one plan to the next.
So medical physicist has to decide which technique should be applied.
well, yes and no. I mean, here, like, well, our preference is always to do VMAT or start with VMAT, you know, and this is a thing in the US, you know, treatments are driven a lot of times by insurance. And so, you know, we'll start with the most ideal or standard of care, which is VMAT. And if for some reason unfortunately, if the patient's insurance doesn't allow it, we'll have to resort to 3D. And so that's usually our decision tree on the mode of treatment. But by and all, you know, the VMAT, at least for us, is considered a standard of care. So it's rare, unless it's a true palliative case, that they would deny that. But like Eric said, the structures should be the same. You know, the nodes, the PTVs and all that. The differences will become in how much, you know, with a 3D plan, you don't have the ability to optimize. You know, you're just putting on, you know, orthogonals or APPA or four-fill, however you're doing it. And so you don't have the, you know, necessarily the need for the rinds and all that, because there's nothing you can do with them.
If you have the choice between a 3D and a VMAT and an IMRT, and you as a physicist have that choice, you're always going to want to shy towards the VMAT or the IMRT, because it's so much easier to do the inverse plan versus the forward plan. Not to mention the whole techniques of doing a 3D head and neck are just, I remember those days, and they were tough.
Yeah.
You have to come up with some way to boost the area over the cord, right? The nodes over the cord, and you do a post-cervical electron strip, and you'll save yourself so much effort by going to IMRT or VMAT.
Right. It is, and we actually hear it from the symmetry, and it sounds counterintuitive, but they say VMAT planning is much easier than 3D, just because of trying to meet these objectives. You know, it's harder to make, you know, keep your OAR constraints down with a 3D plan with beam arrangements, as opposed to a VMAT and let the optimization do the work. And also, you know, to add on to Eric, you know, if these patients are living longer, and so, as you said previously, you know, you don't want to, like, if you have a cord constraint that's 45, you don't want to just say, okay, I'm good at 45. You want to have it much cooler than that, because that patient can come back 6 months, a year, 2 years later and need retreatments in similar areas. If you've already gone through that cord dose, then you might be restricted with what you can do. So,
may I add something else?
Sure. Yes, absolutely.
Sorry, I'm quite new in VMAT technique, but sometimes I'm getting the asks from physician to do a boost in sequence treatment. So let's say PTV has 25 fraction and let's say 3 fraction as a boost. And when I use a VMAT in this case, I have a little bit problem how I can treat at the same time boost and PTV, or how to separate if I use a VMAT in this case.
Well, in the case that we worked on, this pelvic plan was a simultaneous integrated boost. So it was doing, 25 fractions to deliver different doses to different PTVs. So if that's allowable, then I would do a simultaneous integrated boost. If you're going to add on, then you're just going to add, you're going to finish your first 25 fractions or whatever, and you're going to add 3 on top of that with a boost to your PTV.
Right. And that kind of goes into like, if you're doing you don't want to like bump against your constraints with your initial plan. You want to always try to keep those as low as possible, because if you add, a boost or, future treatments, you always want to have that ability to add dose to an area that might be an organ at risk. You don't want to like paint yourself in a corner and not be able to do it because you've already gone to the dose tolerance on that structure. So if you're doing the 25, if you don't do an SIB, you do the 25, you try to keep your OARs as low as you can. And then if you do the boost, you allow that dose into the boost and show the results in the sum plan.
Thank you.
And I want to go back and talk one more thing about the difference between 3D and IMRT and VMAT. You're going to find that if you have the choice to do VMAT, the therapists enjoy that more when they're treating, because it's a lot easier to do a VMAT treatment than it is to do IMRT and it's over to 3D.
Yeah, absolutely.
And that's what faster. It's faster than the patient as well, because you can complete one arc in as little as 1 minute, right?
Right. And to add to that too, it's the therapists like you more. You're going to win points with them, but you'll also have the longer the patient's on the table, the more likely they're to move off where you want them to be. And so if they're on the table for 10 minutes as opposed to 40 minutes, at that end of the 40 minutes, they could be somewhere completely different than where you started. So the quicker you get them in and get out, the less likely you are to move off of your target.
Can I jump into another patient? Another case? Do you mind?
Sure.
This is the plan that did a 12 or 15 field. I can't count that quickly. A lot of IMRT fields, right? And one other caveat was this: it was done with an FFF field size. So and the coverage, the scorecard is good. 93% did well. Missed a little bit on the rectum nod, and that could probably be taken care of by contouring that hot spot in the rectum and just optimizing that out. The one thing that we had to say about this one is you may be needing so many fields because you're using an FFF. Keep in mind this is a very long patient, okay? And remember, with a flattening filter free mode, you've got a lot of dose in the center, and it trails off as you move to the outside. So it's not a flat beam. So you may be needing to block that central axis of the beam with your MLCs quite a bit to get your dose up in the upper and lower areas of this field. So you might be fighting against yourself using an FFF, and you might want to switch instead to a flattened beam for that. So that was one thing we had said about that. I know there was somebody that broke the PTV 4500 up into 5 different PTVs, which was, there's some advantage to that. I can't remember who did that. So if you could if you're on and you did that, I'd like to pull up that plan as an example. And Sean, did you have any more to go through?
Most everybody did really good jobs on these plans. There was just most of the issues were just the maxes, or a lot of the issues were the maxes, which you can take out with that overlap structure. Some of the optimization could have been helped if you're cold on the 45 and such with the optimization structures of the 45 and because it's trying to optimized to 45 and a 55 at the same time, so it battles. Those are the 2 big takeaways from what we saw in these plans, or from the bulk of them. But overall, I think the majority of people. But just so you know too, some of these plans that you see all green on, maybe 100%, they're not always they meet all the objectives, but there may be other issues. You may have some dose outside. You may have, your Ryans might not, or your rings might not be pushing the dose in, and things like that.
For instance, these 2 plans here, there's a VMAT plan and an IMRT plan that you'd expect be doing pretty well, because they're missing. They're really relatively green, right? These VMAT plans, but yet they scored less than something that has even a red on it, right? So this one didn't meet the maximum dose to the duodenum, but yet it still scored 100%. So
There's no perfect plan.
Yeah. Even the planner that I had doing it, I mean, said that some of those things were very, very. Overall, it was a fairly straightforward plan, but there were some things that were a little bit gave him more fits than others. And he's got his master's degree in treatment planning, so he's been doing this for a while, 10 years and so forth. So, all right, that's what we have. Are there any more questions?
Yeah, if anybody has a plan that they submitted that they want us to talk through, I mean, we're happy to do that as well. We didn't want to like highlight them all. We figured 54 plans would be kind of obnoxious for an hour's worth of talk.
And you can see a lot of them are the same, right? I mean, a lot of them have the same issues with maximum doses and so forth.
Right. So yeah, if we pulled any up, we weren't singling out. It was a common thing we saw. So we were just trying to give an example.
Usually we tried to find one that had just like one problem, but
Right.
Well, thank you very much for taking us through these plans and answering all the questions that the participants have. Oh, we have a question coming in from Shireen. Shireen is asking that can you explain how Fluence works in optimization?
So the optimization process is actually designing the Fluence, right? So it's designing the photon flash. That's very different. How does flash work?
Hi, I'm sorry. I get
No, it's
confused
okay.
a little bit. Sorry.
It's okay.
It
We were
would be
trying
a
to- we were
stupid
thinking about
question
that
to ask about Flash.
No, no, it's
The
okay.
thing is about Fluence. The thing is, I wanted to ask how the Fluence works during the flash margins, because I know we use it for. I mean, I'm Monaco planner, and we use it for breast cases, and when I put the structure external, like a bolus structure, and after recalculated my plan, which was optimized with flash margin, it gave kind of hotspots on that bolus. I mean, the fluence was really high on that part. Where's the flash margin part?
Okay, so it's trying to force the dose, make sure you're getting full dose outside onto the edge. I'm not sure. I'm not sure. I haven't dealt with that problem.
Right. Do you use Ryan? Just to try
No.
to. Okay. Do you have a PT? So you're talking about like a breast?
Yeah, it's about breast. I'm sorry, it's out of the topic a little bit, but I still couldn't understand. It was like it was giving full fluence outside of the body because I put that flash margin.
I mean, the breast should have. I mean, you should be open 2 centimeters beyond the breast tissue, right, for a 3D conformal. So
This is an IMRT.
Yeah.
Sorry, yeah, it was actually IMRT plan. And the thing is, we use also IMRT plans for breast cases, and we usually treat our patients without breast holds. I mean, without gating, so in free breathing. And it's advised by Monaco to use flash margin, and I used it. And the thing is, patient has a little bit swollen. She got a little bit swollen, so we took the structures from XVI, I mean condom CT structure images, and we put it back to Monaco, and we override the density. And when we recalculated our plan with the swollen part of the patient, it was like really hot line. Where is the flash margin supposed to be?
Normally, if you don't include a flash margin, does it close the MLCs down to the skin surface?
Yep.
Yeah. So your skin surface will be cold otherwise, right?
Yeah. I mean.
Yeah, because also they say if patient gets swollen, if it changes a little bit the breast shape, so it's advisable to use the flash margin. So here Olga says that it depends on the density of the margins.
Yeah, we're not Monaco users. The concept is probably similar in Eclipse for some extent.
How does it work in Eclipse?
Again, we don't do IMRT breasts with Eclipse, but it seems to me that you would always want a flash. You really would never want to close down your MLC the edge of your surface.
I'm sorry. Can I answer to the question
Sure.
of Shireen?
Yeah, absolutely.
Because in Eclipse for VMAT with a breast, we use these fake kind of margins as a bolus. And usually we use a variety of the bolus, not like a 0 as a matter, but minus 500, something middle in the air, in the matter. So, and then Eclipse creating this area, like 1 centimeter. And when we making the last calculations, we just delete in the bolus. So we have a fluence in the air, kind of like that.
You
Right,
change the
exactly.
density
Yeah,
of
you
the-
do delete it. Right.
Okay.